Healthcare workforce development was the issue that, that we put up. So our group started from scratch, whereas everyone else had a grid to work from completed. We had to start picking our brains right away. We talked about different ways to view what's important about developing the healthcare workforce, and what we ended up kind of coming to a consensus about was working on interprofessional competency and collaboration, and focusing across not only the academic preparation of healthcare professionals, but also the practice setting. So how do you teach health professional students about interprofessional collaborative practice and collaborative care, but then how do you take it into the practice setting and assure that for those people who are already in the workforce that they are able to transform their practice that way, and also that they can support the education of healthcare professionals. So that was kind of our objective, was to build that. Did you find my? Yes. That would be lovely. This is great. It's not helping me though. I was doing okay just for, I'm old, and so, the memory's not quite as good. So a couple of things we talked about specifically was realigning clinical rotations to get to that interprofessional training. One of the specific examples we talked about was the integration of oral health and medical care, the importance and the connection between dental health and your physical health. And so how do you build, as one of the possible team models, that physician-dental relationship, learning to work across levels and break down the hierarchies, and then also to integrate the patient perspective. How do we engage the patient in this whole model of interprofessional care? So that was our objective. In terms of the population level impact, obviously, as with most of these, it focuses on all four levels. It's the patient, providers, the population, and the public. We did an inventory kind of current state initiatives, and again, that was pretty, it was based upon the particular expertise around the table. There are certainly probably many other things out there that are going on. But the big one that we talked about, because one of the things we talked about was, could we take this discussion and try to pilot it in a couple of places? And so the one of the most logical places to do that is through the State Innovation Model Grant, which will be testing a new delivery model of care in the state. And within the plan that was originally drafted, the blueprint, it does talk about interprofessional education and interprofessional collaborative practice. So the suggestion was to take a look at how might this initiative and the SIM be melded together. We also, we talked about the Michigan Public Health Institute, which helped us write the original planning grant, did quite an inventory of what was out there in terms of best practices, and we thought they could probably help us identify practices where there was interprofessional care already going on that we could use as best practices. We talked about the AHEC, the Area Health Education Centers. We talked about Senate Bill 568 as another vehicle that builds on interprofessional care. The Michigan Health Councils, we have a product called Education to Practice. How do you take and educate interprofessional education, and then make sure that when those students go out to practice that they have that opportunity. We talked about what goes on at the Keystone Center with MHA on patient safety as a place to look at what's going on. And we looked at the University of Michigan Dental Clinic has some things going on around dealing with special needs kids. And then DCH's integrated care for the dual eligibles, Medicare and Medicaid. So we have a lot of things we can turn to as examples and that we could build upon, with the idea that we would actually look at trying to pilot a couple of things somewhere. Requirements, we felt it was very important that we needed to have champions out in the facilities. That's one thing to have educational champions behind this, but you have to have faculty champions, you have to have practice champions. That we need to make sure and have insurers who are engaged in this because they have to pay for what this looks like. Executive support in health systems and schools, legislative support, practitioners across health disciplines, sharing of educational resources, and joint development and delivery of training. So those things would all have to be in place in order for us to go forward. What we said we already have in terms of enablers, the Michigan Health Council, we have a series of tools and resources for interprofessional education and building some on interprofessional practice. We've done some work with FQHCs on using that model, but they also represent a great network of facilities where we could pilot some things. University of Michigan, and I'm not sure, enriching patient experience. We have the ACOs who are already looking, paying for value over volume. And again, the state innovation model opportunity does the same thing. We talked about simulation around the bedside and focusing on workflow within the system, and mentioned particularly Central Michigan University and Western Ontario. The other thing is an enabler culture that allows and corrects for errors and controlled and by the relative simulation that lets us practice on people without hurting them, which is always a good thing. And the last enabler was we have a great model at Cherry Street Services in Grand Rapids area for how this integrates with behavioral health in terms of interprofessional education and practice. So a lot of great things in place already that can help us do that. Obstacles, one of them is, I hate saying this word, scope of practice. Regulatory restrictions on what people can do in terms of the definition of a particular profession's practice, what a doctor can do versus a nurse, practitioner, those kinds of things. It takes a long time to change. Health literacy is an issue to get patients to recognize a different way of how providers might be practicing. And again, the payment systems and having payers on board is potentially an obstacle. Patient discomfort, because they may not be seeing, they may be used to seeing a physician, and going forward in this model they might be seeing other kinds of people, and that might be difficult for them and make them uncomfortable. We talked a little bit about the supply and demand of health professionals as a bit of an issue because we have a mismatch between the demand and supply in terms of a gap. And then also initial productivity loss as you move from the current models of delivery to a more interprofessional. It is a slow process and people are not nearly as productive as in their practice, and so that was something we needed to recognize. In terms of measures of success, we talked about things like possible ways to, one of them was to, we have a practice that we're familiar with that took a look at how much more they received in insurance incentives, payer incentives, once they implemented interprofessional practice. And what they found was they got, over a couple of years, about 1.2 million, they're a very small practice, 1.2 million in additional incentives because of the productivity and the way and the clinical outcomes that they achieved once they started practicing in an interprofessional way. So that was one measure we came up with. We also talked about the patient satisfaction, communication, respect. We looked at talking about using HEDIS measures to identify some things in terms of patient satisfaction and outcome measures that could help us tell if we make a difference once we're working in an interprofessional model, and looking at patient experience versus satisfaction, decreased waiting time. And one of the things we talked about was transparency and organizational candor. So that completes, we didn't have baseline values because we didn't have any data here. But we did identify that there are some people missing from our table, and so we just made a list of a bunch of people that we still think we need to engage in order to make sure all of the major stakeholder groups are represented. And we've got that list to work from. And we talked about next steps. The Michigan, somehow there was a collaborative vote without me. And I ended up the team champion. You should never look down at your paper. But anyway, so the Michigan Health Council is going to take the lead in convening this group once we understand a little bit more about our next charge. But if we pull together, we would be talking about ongoing sustainability of convening our community of interest, getting a common understanding of our charge, so making sure we have sponsorship of the charge, whatever that should be, developing a shared platform for us to do our work. And again, we'll talk about clarification with chart where we go next. But certainly understand we need to be clear about what our purpose is. We think we have a good start for having a little bit of time to work on it. So that's what we did.
We have a theme champion, and he, she is me. So I think a lot of our discussion involved around who to include in the stakeholder groups and who to add and who to recruit and how to recruit people, and kind of return on investment for different participants in it. So that was a lot of it, and we talked a lot more about some of the details of the systems and things that we don't have to go into here. I think I'm trying to remember the 3 take-homes that we had. We had it on a chart. Mary wrote it in orange though, so I couldn't read it. No. No, Mary did a great job. She got really good chart handwriting. We talked about how, identifying resources to support not only the implementation but the effort toward the implementation. We talked about again identifying and specifying stakeholders and participants in the group. And taking those folks to develop, then looking at our product, because I would describe the meeting as more kind of stream of consciousness, kind of Jim think today. And so to take that content and isolate it into kind of problem statements, and take those problem statements and then develop kind of new outcome measures, and take those outcome measures and make that the product of our group. So that's where we were at.
Well, while I may have jokingly said I was going to pick another group, I stuck with the musicians because that's where my heart is. So you got to stay where your heart is and what you really believe in. When we looked at a theme champion, we actually never chose one, and we're going to talk about why. It goes to the stakeholder group. I mentioned this morning, or I talked this morning about the state work group initiative that's in place. And we really felt as we focused through the morning that we were going to have 2 cycles going if we didn't look at this established group that's been working for 6 to 8 months, which includes legislative support, strong legislative support, which is important in any endeavors for musicians when you're looking at changing mandates or rules. So we really thought we would throw it back to your group to look at how these groups might become one and mesh. And our leaders in there were great with that idea, so I said that's fine. But if not, if we had to actually identify at this point in time a theme champion, I would make it my division director who went out of town and left me here. So that would be it. No, in all seriousness, this is really increasing these objectives is a statement, is our state work group. This is what we want to push forward, and we would certainly be willing to take on the championship. But we may endeavor a new champion when we look at the stakeholder group in that state work group that's already out there. So if that makes sense, that's where we're at. We did, though, as a group, we came up with some really great discussion today, and it was really nice to hear from some different partners that are out there, and I appreciate the people that joined me today. Under requirements, we really looked, the group wanted to add data analytics to look for more data or diverse data through our registry. And then because there is the state work group looking towards different requirements for school waivers, we added in vaccine literacy prior to waivers being signed, which is part of their initiative. Under enablers, we had to look at history, and I thought it was a good one to add history of immunization success, moving from 50th state to 22, even though we're still at 70%. That's a big jump. And as a member in the group mentioned, we have 5 counties that are looking at decreasing waiver rates now and have had success. And so we want to look at that success as well as a baseline for enablers. And of course, the state work group would be another enabler that we have. Obstacles. It's a politically sensitive issue anytime you ask for legislative changes in rules, and so we acknowledge that that would be one of the obstacles that we have to look at. And currently waivers are being handled in schools at the school level, so that would be another obstacle that we would be addressing. And I think that's about all we actually wrote down on paper, but great discussion. I really appreciate all the people that joined us today and the opportunity to present this and to look at this as a learning cycle. Thank you.
Our team did a great job. We were in such a level of communication that we never used the word champion, but it became obvious that I was the person who was going to be doing that role after the meeting today. What we did with our group is we really created, I think, a much more in-depth understanding of what it meant to have an interaction, a productive interaction within a healthcare delivery system that would achieve promoting people as better stewards of their own health. And we had a very sophisticated group from the standpoint of understanding community health. And a few of the sort of notable things that were discussed was, number one, it's important to remember that people acting as better stewards of their own health is fundamentally something that has more determinants related in socioeconomic, demographic, and community-related things than necessarily related to healthcare things. And it's important to make sure that the healthcare community and this particular annual exam fits a supportive role to a much broader community effort to have all of us be better stewards of our own health. And that included the notion that when a person has these annual visits, they should be having them with a provider team that's connected with community organizations and connected with other elements in the community that would really create that type of synergy. We realized that this role of promoting people being better at taking care of themselves is not a once-a-year type of thing, and it requires a lot of thoughtful time and attention. So it really means that when we go about designing or redesigning this service, that we have to make sure that we get several things right. One is we take off the plate a lot of the work that is currently not really contributing to better outcomes and replace it with giving people time to be able to explore the issues as to why it is that people are sort of set in the health behaviors that they're set in and what types of things would be necessary for that to change. And it was very apparent that this would require a team. The types of providers that people thought would be effective for themselves was quite diverse and quite dependent on the types of challenges that they might be facing. So a team-based approach was also something that was thought to be very important. What we're going to do, because we really didn't have process owners in our group, we agreed that what we would do as a group is go out and find people who are delivering annual visits as part of their daily work and are motivated to get on the learning curve to do this more effectively in tandem with people. We thought that it was a pretty integral thing that they should be connected with someone who's available to improve the patient portal aspect of it, because the notion of continuous interaction through that portal was viewed as an important capability. We are going to solicit a team that's willing to work on this from a learning health system perspective. And so we defined a process by which we'll be communicating in the future as a team to sort of assemble a new group that will be more appropriate to the ongoing task of changing how healthcare is delivered.
We took notes, but they're short. And for those that were in the group, please add. We did improving coordination of care, and just some of the ads that we thought about. There was general consensus around that we should probably focus the scope to reducing readmissions, although the group acknowledged that admissions as a goal is something that we should certainly keep in scope and at least be able to collect information and data on. that probably reducing readmissions is just probably the tip of the coordination of care iceberg, so to speak. We did, when we went into current state and understanding our state and current state initiatives, there is certainly a whole laundry list of different programs that are going on, and we thought the value there was to be able to catalog all these different programs that are going on, understanding their scope, their geography, the numbers of populations that they're currently outreaching to, and be able to identify those common data elements that we hope to be able to capture in the future. The requirement category is where we spent most of our time, specifically understanding data requirements, both from an IT perspective, but also a new data element that we identified was the ability of our program to identify the care coordinators. So we all agreed that we have too many care coordinators, and we need a consistent way of identifying those care coordinators and being able to capture that information and to share it along the continuum. We talked about accountability care coordinators, is who currently has the baton for care coordination, and how we capture that information and then communicate it along the continuum. Consistent in unique patient identifiers, right, Tim? That was Tim's. Sounds like a Tim element. A consistent identification of the provider as well was another element. Let me see. Some enablers. Let's talk about the model of care. There was general consensus as we talked through the different models of care currently in our state around care coordination that MyPICT or a MyPICT-like model was likely the one for which we had general consensus to adopt and to use that as our care coordination model going forward. Under the enabler category, standard data definitions, again, not only understanding the data collecting today, but also the ability to collect new data elements and to be able to share them, and the flexibility of our the systems to be able to share and communicate those along the continuum. Understanding how to share what we're currently learning. The suggestion is that we set up a SharePoint type application, so that because there's multiple types of initiatives going on, not only nationally but just even locally within our state, that we should have a single point where people can go out and learn and have discussions about what current best practice is, so maybe a way to kind of accelerate and facilitate some of the learnings. Under the barriers and the obstacles, we also talked about continuing to work towards getting better payment alignment. A new one that was brought up was consent management infrastructure. So we had an attorney who was an expert in privacy and data management, and pointed out that as we're dealing with this multitude of information and data, that we have to have some rules around how to share this information. And so that, as well as data ownership, was another obstacle. And then finally, last, measures, both baseline and targets. I think we all agreed to probably adopt the current commonly accepted definitions of reducing readmissions, but we also acknowledged we need to track admissions and also be able to understand populations of readmission, both geographically, acknowledging that care is still local, and there's going to be local and cultural variances that impact admissions and readmissions that aren't going to be applicable at a statewide level. Additional participants, payers, patients, family, caregivers, and behavioral health are people that weren't in the room today that we thought needed to be in the room tomorrow. And then probably the most important was that Brittany from MHA Bogan has agreed to be the lead and to pick up the baton and carry this work forward with, I think most of the people in the room had continued interest and will continue to participate.
As much as our group loved diversity and variation, we also resisted constraints. So we didn't really stick to the format of enablers requirements. So we just had a free-flowing conversation. Actually, we had a very good conversation about this issue. And I have a new best friend, Kate, who's going to be the lead on this, and I think everybody in the group agreed that they wanted to continue to participate. We had some very interesting conversations in terms of challenges or obstacles, whichever terminology you prefer. And what we identified and really kind of spent quite a bit of time initially just talking about the whole concept of what are appropriate incentives when you're trying to change behaviors. And we had a variety of opinions about that, to the point where we decided that we needed to limit that conversation, since we all had so many different great ideas about different ways that you could incentivize behavior. I think one of the best points was that everybody has different incentives for what they do and why they do it. And the current structure of healthcare is sort of set up to create the outcomes that we've received, and the needs of the population we serve have changed dramatically in the last 50 or 60 years. And I think everybody was on the same page that whatever we do, it has to be different than what we're doing now if we're really going to move the needle on quality and see an improvement in the health of the population in general. So we kind of agreed to agree at that point. We then started talking about how we would come up with a set of measures. And the enablers that we identified is that there's a lot of work being done nationally and at the state level about quality definitions. We had some pretty good expertise in the room, people who've participated in NQF and NCQA, and they shared quite a few insights with the rest of the group in terms of the process that they go through. We kind of thought that that would be a great jumping off place and enable us to move a lot further and a lot faster, because we don't have to recreate the wheel. And then, of course, the obstacles that we identified were that everybody was not in the room. We needed some additional stakeholders. We wanted more purchasers. We wanted more leaders from payers. We wanted more representation from the payers in general and from consumers, as well as more providers and healthcare systems, things like that. So we really thought we had to expand the number of stakeholders to discuss this. What we thought as a target was, the real target we thought was getting to a universal set of quality metrics that everybody could reach consensus around, that would represent a good body of work for all payers and all providers to sign on to, as well as purchasers of healthcare. If we could get everybody to agree that this was the quality metric that we should all be striving to improve, that would go a long way to cutting down on the confusion and frustration that currently exists in healthcare. So that's kind of my synopsis, and I don't know if anybody wants to add anything that I left off. I tried to put it into the various buckets, but it was really a great conversation, and I think everybody was excited about working on this through the Learning Health System going forward. So thank you.
So our group was charged with looking at shared patient decision making, and when we took a look at what our objective was listing at first, we realized that certainly was a piece of it, what we had outlined, but it's really broader than that. And we actually, our big takeaway was that we want to create a framework that'll address this in a larger way. And this, of course, doesn't just impact consumers. In fact, we want to kind of broaden that definition as well too. We see providers, of course, being a key piece of this. Purchasers came up. A number of different groups fall into place with that. Let's see. Requirements, adaptability was a biggie. We also, as kind of a free-flowing conversation, had a lot more discussion on what obstacles are at play. And I also want to mention, and in fact, my colleague over to my left was making fun of me because I came with handouts that were made, and I call it proper planning, and that's things. And that leads me to my point that our group has named myself and Shannon Stoltenberg Wing as champions of that, and Shannon is credited with these handouts, another one that was given out as well too. And the base of our discussion is that Shannon's group out of MPHI is currently doing a tremendous amount of work related to this area in particular. And so we want to leverage what that group is doing and kind of broaden it a bit and take it even a little bit further with what we're trying to do here at the within LHS as well too. So we learned a lot. We kind of identified some things that are already in existence, and we see a lot of great momentum up ahead. With that also, we kind of acknowledge that I think that there might be some coordination points with Dr. Simmer's group as well too, to a certain point. It's judging from your synopsis that you gave too, I think it might be important for our groups to kind of touch base and kind of see if we're all kind of aligned in a good strategy. And definitely there is momentum to stay connected and keep moving this forward, and we also are looking to possibly connect by a listserv or a SharePoint or something along those lines. So next steps, as we kind of identified more what our objective is about, the next question is, okay, what are we going to test? So that's kind of something we're looking to identify and doing a little bit more research both here in Michigan as well as in a national spectrum. And again, continue to leverage what already exists and see what gaps are out there within that as well too.
So great reports by all of you. Thank you all, and thank everybody here for the really rich and robust discussions that you have had. And I want to just say a word about the laundromat and then conclude with what's going to happen next. Because many of you asked, now what are we doing the laundromat, or how does this fit with the laundromat? And actually Megan's last point was a tremendous example of what the laundromat looks like here. So you heard Megan say that their group realizes that they need to connect with Tom's group. And Tom's group actually recognized that too, because they said, you know, we really need to focus on consumers, patients, providers, et cetera. The disease surveillance group in their conversation said, someone in that group said, you know, I know you're tracking where there's salmonella outbreaks or whatever, but I'd really love it if it popped up in my patient portal to tell me where these issues were. That's a cross-cutting issue among all the groups. The idea of having even just common tools, things like data use agreements that cut across, legal documents that can be helpful to all of the groups. Everything down to a SharePoint site that people can have a common, so they only have to learn it once. So you're not doing multiple things in multiple different ways that are all really common. That's what the laundromat is. And that's what we want to do across the groups. So as a planning group, and we want to create a sort of an infrastructure group to oversee this, we want to align the levers that will enable each one of your groups to be more successful collectively than you would be individually. So we're going to need to go back, and we're going to summarize everything that came out of your groups. We're going to look as a group to across those groups to say, what are the common themes that came out where we could develop a tool that would help you to be successful. And we'll do that for all of the groups that are going forward, even the new one. Milani, you're not on your own. We'll do that for you too. You're embraced now by the Learning Health State. So that is what we want to create. We want to create this overarching infrastructure to advance all of these initiatives and new ones that develop over time so that people can build off common tools and not have to reinvent the wheel all the time. And we just need to look at really the output of what you said to see what those common tools are. But I think you heard a lot of it actually in the report outs today. It's really quite exciting. And then, of course, you are going to work within your groups, and all of your groups are working cross-state, cross-sector, and many of you identified new stakeholders you want to build into the group. So there'll be those two levels of work going on. The infrastructure support to help you all move forward, and your individual work that you will lead in your groups. Our next step is to, of course, debrief this session today, and that'll be done by the planning group, and we'll do that fairly quickly. We will also get back to all of you who've attended today. Information, please let us know if you do not want us to share your emails or phone numbers among each other, but otherwise we will send that back to you along with the slides electronically. If you have additional people you want to bring into the effort, if you think about things as you go home and you want to add ideas to that, please email Babette. She emailed all of you already to get you here. She'll email you again to send you the materials from that. So you will have her email address. But if you really are burning to email her today, it's brlevy@umich.edu, and you can email her on your way home as long as someone else is driving. We also, as I said earlier, want to create sort of this infrastructure support group. And so again, if any of you want to be on that group, please do let us know. We've already had some volunteers for that, which is great. So we're going to do our work in creating that infrastructure, looking at the report outs from the groups, figuring out what each of you need, talking to the theme champions who got identified today. We're going to do that over the next couple of months. It is our plan that in the fall, those of you who volunteered to work on a theme, plus any others that you decide you want to bring into that theme, will convene. So some of you get the summer off, not everybody. Anybody who's said they want to be a champion doesn't get the summer off totally. But we're going to do the planning for the next phase of this initiative over the rest of the summer with a launch in the fall of the groups to actually move forward. Now, it doesn't mean you have to stop moving forward as you've got energized today. It's just we're going to be more formally in touch with you to launch you officially in the fall. So those are our next steps. Before I close it out, questions, anything that I haven't answered that you want to know about in terms of where we're headed from here? All right, then again, I want to thank our planning group. I want to thank all of you attendees. I want a special thanks to Babette, Leah, and the entire CHART staff who came and did a fabulous job. And have a lot of work cut out for them. You gave them great feedback and great fodder for the next step. Very exciting. Great to see your energy. You have inspired all of us up here. I know that. So thank you very much.